Bye.
Hello, everybody.
Good evening and welcome to one and all. Greetings from Sexual Medicine Committee Foxy. So, my dear friends, as we know, we are in our mission of sexual health to all. So, today we have this mission to the 5 societies of Punjab. And on behalf of Sexual Medicine Committee, I welcome to all and I thanks to all the president and secretary of the 5 societies who consent to be held of this webinar. So at the beginning, I would like to invite the person who is behind all this webinar, and without his guidance, without his blessings, this can't see the day of a light, that our own chairperson, Dr. Neeraj Jadhav sir. So I would like to welcome Neeraj Jadhav sir to give an overview of about this program, what is the sexual health to all. Over to you, sir.
Thank you, Apurva. So I am really happy as a chairperson of Sexual Medicine Committee. So many societies we have already done, and today we are going to do this webinar on sexual health with the Amritsar, Ludhiana, Firozpur, Jalandhar, and Chandigarh society. So I am really thankful to President and Secretary of all this society who agreed to be part of this webinar. And I'm thankful to our President, Dr. Pai sir, our Secretary General, Dr. Madhuri Madam, and my Vice President in charge, Dr. Asa Bakshi Madam, who always encourage us and always support us in all the activities done by the Sexual Medicine Committee. As you all know, sexual health is very important. Around there is a 40 to 50% incidence of sexual dysfunction. So that means around every second or third person have some sort of sexual dysfunction at some stage of their life. But when we look into the reality, it is a very ignored topic. We hardly talk about the sexual health with our patient or in general, because there are so many reasons. We are not taught about this topic in our medical college. There is a taboo associated with the word sex, and there is also time constraint in our busy activity. So all these factors contribute to this negligence about this very important topic. But how can we forget if we want to improve the overall sexual health of our women? So we must focus on the this very important part of the sexual health. And believe me, we don't have to be sexologists. Like we do so many basic practice, like do basic sonography practice, we do basic oncology practice, so many basic practice we do. We are not that much expert in that field, but still we do as a basic practice as a gynecologist and obstetrician. So same way we can handle and help our patient with the sexual dysfunction, because it will be once only important thing is that we have to start taking interest in this field. Once you start taking interest in the field, you will open up to so many your knowledge, and it will ultimately to your patient. So if you want to learn after today's webinar, I'm sure you will be more attracted to this field. And if you want to continue with the to gain the knowledge about this sexual health, you can join our Facebook group. We have an Insta group also. So join there and you can continuously update yourself. And we are also doing some masterclass series. We are already done 2 masterclass series previously, and currently we are doing 1 masterclass series on the psychosexual health. So you can join that masterclass series. Details of everything you can find on our Facebook page or on the Instagram of our Sexual Medicine Committee. And one important thing, we are also doing one survey which is on the sexual medicine practice among gynecologists. So when I send the certificate, I will send the link to all of you. So please take a time. It is a not very long survey, just few minutes, and you can complete the survey. It will be very helpful for us to know about the status of the practice of sexual medicine among us. So happy learning. and join our mission of the better sexual health for everyone. And I welcome once again to everyone for today's webinar on sexual health. Thank you. Thank you very much.
Thank you, sir. Thank you for your kind words and for the insight of this program. So before I start the program, as we all know, in our culture, when we start some auspicious or some good thing, we are always getting the blessings from our seniors. So today we are really blessed that we have a lots of very seniors and respected persons with us. So first, I would like to invite our Secretary General Foxy, Dr. Madhuri Patel, ma'am. Ma'am doesn't need any introduction. Ma'am, in a true sense, is an example of women empowerment, being the first female Secretary General of our vibrant society, Foxy. So thank you so much, ma'am, for always your blessing, for always, your guidance. And over to you, ma'am, for your words and for your blessings. Madhuri, ma'am.
Thank you, Apurva, for your kind and warm words. Respected our President, Dr. Rishikesh Pai, who is most dynamic and visionary. Then we have Dr. Asha Bakshi, our Vice President, as well as today's chief guest. Then, of course, Dr. Neeraj, you heard just now, excellent committee chair, and he has really sensitized not only our members, made them aware, but also the population. And he has enumerated so many activities he has carried out. So, Neeraj, I really congratulate you for the same. Then we have Dr. Suvarna Khadilkar, my best friend, my colleague, and today's chief guest, and she is Deputy Secretary General, and she is going to take over once I finish my tenure as a Secretary General. Then we have a guest of honor, Dr. Lakhbir, Dr. Saroj Khanna, Dr. Iqbal Ahuja, Dr. Surjit Kaur. Then we have a program coordinator and Master of Ceremony, Dr. Apurva Datta and Madan Kamble, and I must say that they are doing excellent work. Then we have Dr. Dilpreet, Dr. Sarvajit Kaur, Dr. Vanit Kaur, Dr. Harpunam, Dr. Sindhu Lakshmi, Dr. Pooja, Dr. Neelam, Dr. Sukriti, Dr. Savarna, Dr. Preeti, Dr. Gitanjali, Dr. Chima, Dr. Vrejbala, Dr. Sweta, Dr. Kulvinder Kaur, and all my dear friends. Very good evening to all of you. At the outset, I would like to thank the organizer for giving me this opportunity. As a Secretary General, I always take the opportunity to say something about Foxy. Because Neeraj is doing this webinar with the Punjab Society. There are 5 societies. And let me tell that I had been to Ludhiana and I had a wonderful time. I think Gitanjali and Gini were there with Vidu. And I had a wonderful time over there. And from there, I went to Amritsar. There also, I had a wonderful time. And as I mentioned, I always take the opportunity to talk about the Foxy. And that is, Foxy is the most vibrant, prestigious, and one of the largest OBGY professional organization in the world, with 266 member bodies and about 39,500 members who are committed to women's health. And let me tell you, all 266 societies, they are very vibrant and they are actively involved in all the academic activities as well as the community activities. And we have a 28 committee chairs, and Neeraj is one of them. They are given the focus work and they are doing excellent work. I will not talk about journal or ICOG, but today I would like to mention, because my president always says that you should talk about the 2 policies in Foxy, what we have. These 2 policies are, one is professional indemnity policy and second is social security scheme. So I want all of you to take the benefit of professional indemnity policy, which is very minimal, whatever amount you want to secure, but it is minimum. We have tied up with ICICI Lombard. And secondly, the in-between person, the third parties cover you. So I request you to become a member of this policy. The second policy is social security scheme. which, it is going very slow. I don't know, somehow the other it has started in 2004, but now hardly we are having about 1750 members. When initially we started, we used to contribute, each member used to contribute 100 rupees per that fraternity, but now we have increased to 300 per that. So it is coming, your nominee will get immediately, once they produce the death certificate, immediately about 4.5 lakhs. So I want all of you to become member and take the advantage, right? And what we have observed, the people become the member of Social Security only after the age of 50. So that becomes very difficult. And therefore, I want youngster to become member and take the advantage. And of course, we'll take out some policies that when the youngster becomes the member, then after particular years, we will not take, their, debt fraternity contribution. That we are just planning. It is just on the pipeline. So we want more and more people to take the benefit of these schemes. And of course, as far as the sexual health is concerned, and Neeraj has pointed out, the women are considered as the non-active sexual partner. And they are ignorant about the fact. And if people, women who understand, they don't come out openly. But now with the education standard has improved, we see many patients coming to us. And as Neeraj has mentioned, that it is never mentioned in the syllabus of our MBBS or MD, right? Plus, there are no, books are available. So what we learn from our experience and reading from the other, research articles. So these are, we are giving to all of you. We are making you aware. We are sensitizing you, and we have to give best to our women. So today we have a eminent faculties chairperson who are going to talk about the sexual health. And I saw the topics are fantastic. And they are going to enlighten us on the topics which will help us in day-to-day practice, so which will benefit our women. I congratulate again for the team for the most apt webinar, and I wish them best luck. At the end, I would like to quote Nelson Mandela. Education is the best weapon. When used, can change the world. So dear friends, let us use our education to update our knowledge and give the best to our women. Thank you once again for giving me this opportunity.
Thank you, Madhuri madam.
Thank you so much, ma'am, for your kind words and for your insight of the topic and everything. So I would like to invite my co-moderator, Dr. Madan Kamble sir, to please introduce the chief guest for today. Very dear Dr. Shavana ma'am and Dr. Asha Bakshi ma'am. Madan sir, over to you.
Yeah. Good evening. Thank you, Apurva. I would like to thank Foxy Sexual Medicine Committee and the Foxy Office Bearers for giving me this opportunity. I welcome all the faculties and all the chief guests of honor for this today's webinar. It is my pleasure to introduce today's chief guest, Dr. Asha Bakshi ma'am. Actually, there is no need of introduction. She is so humble and always with us for every program, and always gives us blessings for any program of Sexual Medicine Committee. Dr. Asha Bakshi ma'am, she is the Vice President of Foxy, and I would like to request ma'am to give blessings for us. Over to you, ma'am.
Thank you very much, Madan and Apurva for coordinating the whole program. And I would like to congratulate Neeraj for such good programs always. And he has really brought a new kranti, a revolution in the field of sexual medicine. Every gynecologist now is aware of the common sexual problems. I think you don't have to be really great, but at least few common problems you have to know. So that's what he's doing, and I'm really proud of him. And today I'm very fortunate that Dr. Madhuri Patel has blessed us, and she's very true that it's very important to become the member of Social Security Scheme and the member of indemnity. Even I have taken, and I think in modern days it is very important, and we all should do that. And so fortunate to have beautiful Dr. Suvarna with me as a chief guest. She is a beauty with brain, a multi-talented person. And it's so nice to see Honorable Dr. Dhariwal, Dr. Lakhbir Dhariwal, and Dr. Saroj Khanna, Dr. Iqbal Ahuja, Dr. Surjit Kaur as guest of honor. And today the topics have been selected very well. And I'm sure Dr. Dilpreet Sandhu, Dr. Sindhu Lakshmi, Dr. Suvarna, and Dr. Brijbala Tiwari are really going to give us very good learning points. And we have very well selected chairpersons, Dr. Pooja Dhaliwal, Dr. Neelam Sodhi, Dr. Sukriti Sharma, Dr. Preeti Jindal, Dr. Gitanjali Kaur, Dr. H.K. Chima, and Dr. Shweta Agrawal and Dr. Kulvinder Kaur. So it's a very good conglomeration of the faculty today, and we are really going to learn a lot. So, and we all know that Neeraj is a very, very active person. He's besides these webinars, he's doing lots of other things like the courses on sexual medicine, then the leaflets on sexual medicine, and survey. Please, whenever that survey comes out, we all have to participate so that we show that, because what happens, it's not just knowing the things. I think we have to really show how academically strong also we are. So all these things bring us on a better platform. We are very good clinicians, but we are not showing our whatever we are doing, we are not able to show. So this is the way we can show. So please do participate in the survey. And I'm sure, Neeraj, one day you are going to bring out a small pocket book of sexual medicine for all the gynecologists, and I'm with you for that. So all the best and keep doing the good work, and let's have a happy learning, as he says. Thank you so much.
Thank you, Asha.
Thank you, Asha ma'am, for your kind blessings. As always, you are with us. I would like to invite our second guest of honor, Dr. Suvarna Khadilkar madam. She is the Deputy Secretary General of FOXI. She is a professor and head at the Medical College Mumbai. And she is a great academician, lovely person. And as ma'am has rightly said, she is beauty with brain. And I would like to invite ma'am for blessings. Over to you, madam.
Thank you so much. I hope you all can hear me.
Yes,
Very good evening to all of you. It's thank you so much, Dr. Madan, for those kind words. And thank you, Dr. Apurva, for coordinating this whole program. At the outset, I really would like to thank Dr. Rishikesh Pai, Dr. Madhuri Patel, Dr. Asha Bakshi for having this program on this committee of sexual health committee. And I must say, I have been seeing Dr. Neeraj working so hard on this committee. I mean, he is one example what one can do on a committee like this on sexual health, because people don't want to talk about it, neither the patients nor the doctors. And on the even FOXI, usually I heard there are no sponsors for this particular committee, so it's very difficult to organize programs. And I have seen Dr. Neeraj has organized so many programs, and I think Dr. Madhuri was kind enough to, give our platform, our FOXI's platform, to organize these webinars, so that you don't have to spend, you don't have to seek any sponsor to conduct good programs, good academic programs like this on this committee. So, Dr. Madhuri, I think we have really offered this platform to many committees. And I think Neeraj is one of those who is really utilizing the platform more than in other committees. I think they may seek from other sources, but I think FOXI is giving platform, and we must inform all of them that we are having this platform. Now, coming to today's seminar, sexual health is so important. Today, as we said, less talked about, but very important in, I think, women. It is almost 43% of women are suffering from some kind of sexual dysfunction, and there are about 35% of men will be having sexual dysfunction. But I think they don't talk, they suffer, they don't come out with it. And I think our job is to have a dialogue with them, and you need to have a direct questioning. regarding for what they have come. Maybe they have come for that particular dysfunction, but they do not come and tell openly. So we can easily, whenever a patient walks into your clinic, you can talk about it openly, ask direct questions, and then make them comfortable with you. And I'm sure they will start talking about it. So I must really appreciate Dr. Neeraj for this. And, in the whole program, I see so many dignitaries and so many prominent names from Punjab, societies, Amritsar, Ludhiana, Jalandhar and Chandigarh. All these 4 societies have, I have visited so many times, not even once, except for Firozpur. I think I have visited all the societies, and I know all the people there are very, very academically oriented and they want to progress. I can see my dear friend, Dr. Surjit Kaur. She is little silent. She has not come up. But, in 2017, she was the one who had organized this, I think, North Zonal, our IMS conference, water conference she had organized. I still remember her work. I can see Professor Dhaliwal here, Dr. Saroj Khanna, Dr. Iqbal Ahuja, who has been working in almost all societies. And he is really very active member and very, very dedicated member, prominent name in Punjab. And Dr. The speakers for today are Dr. Dilpreet Sandhu, Dr. Sindhu Lakshmi, Dr. Sawana. I can see her, she's full of energy. I'm sure she's going to give a great talk. And Dr. Brajbala Tiwari. So all these are excellent speakers. They will enlighten the audience about the various aspects of these different diseases, like vaginismus is so common. Then, FOD, sex and sexuality in pregnancy, such important topics have been covered by Neeraj. And I'm sure all of you are going to have wonderful time in this webinar. And I wish all of you all the very best. Thank you so much. And I don't think I should take any more time, because I am sure people are waiting to hear from all these wonderful speakers. Thank you so much.
Thank you, Suvarna madam.
Thank you so much, ma'am. Thank you.
Thank you, Suvarna ma'am, for your kind blessings and taking time for us today from your busy schedule. I would invite Dr. Apurva Kumar Datta for further proceedings.
Apurva.
Yeah,
So I would like to invite the guest of honors for today, and we have a very senior Dr. Lakbir ma'am. Ma'am doesn't need an introduction. Ma'am is the past HOD of the prestigious PGI, and ma'am is actually credited with the establishment of the first IVF center in a government setup. So it's a huge, ma'am, achievement. So thank you so much, ma'am, for giving your time. Ma'am, over to you for your kind words and blessings.
Okay. Thank you, Dr.
Lakbir, ma'am.
Apurva. Good evening, colleagues. Actually, I'm very happy at the initiative of FOGSI to start this committee on sexual health. And that's the area which we were not taught or trained during our training program. And frankly speaking, we have not also taught to our residents of this. And not only that, and then we do not bother to ask from patients about this, the issues, many issues they are having. At the most, we may be, if they ask about sex in pregnancy, we may just say, we will think of whether she has had abortions or premature labor. Then only we will tell her directed. Otherwise, we do not bother much. Or another area may be vaginismus. Yes, that vaginismus also, if they come with infertility, then we pay more attention and we talk more of this. So I'm very happy that you are sensitizing gynecologists. So which is very important. If our own hesitation goes, then only we can ask from the patients. And like we ask all the other history of menstrual problem, dysmenorrhea, and menstrual losses, heavy or whatever, we should ask directed questions about the sexual health. Maybe then only patients will come out. That is very, very, very important. So commendable this committee is doing this job. That is very nice. And I would rather say that it will be very nice if some directed questionnaire is made, which we can ask from the patients. Very handy to all of us. Like Madam was saying about a pocket book, that what we should be really asking. And a part of the, if Foxy also can take action to make this a part of the PG training program, then definitely if those young gynecologists, they come out with this, they start this, of course overall things are a bit changing. The women used to consider this talk as a taboo, but now with the overall things are changing. Rather, we are not very good at that. They come out with the questions and then we get taken back, and we also have to think what to answer, and maybe we are not giving them satisfactory answers. So by attending these meetings, sensitizing more of us again and again, our own hesitation will go and we will help our patients. So, wish you all happy learning and happy Ashtami. Thank you for inviting me.
Thank you.
For
Thank
this.
you so much. Yeah, ma'am. Thank you so much, ma'am, for your kind words and for giving and enlightening us. So next we have very senior Dr. Iqbal Ahuja, sir. Sir, again, does it need any introduction? Sir is credited with the first IVF child of that reason. Sir is the, the patron of the Ludhiana Society and a very senior and great academician. So thank you so much, Iqbal sir, for accepting our invitation. Over to you, sir, for your kind words. Iqbal sir.
Thank you, Dr. Purva, Dr. Neeraj, Dr. Madhuri, Dr. Bakshi, and Dr. Swarna. I met you years ago in Jaipur. And from Punjab, we have got Dr. Chima, Dr. Dhaliwal. I think I've got a galaxy of doctors which I can see. Very senior, very intelligent. Thank you for giving me the opportunity of being a guest of honor. It's a subject which is very difficult. Like every lady is a gynecologist and every male gynecologist is sex specialist. They expect from you to know. Once I was reading that subject of sexology is not known to anybody actually. They know only from their personal experiences. And then they try to retain the complaint of the patient with their own experiences, and then they tell. Years ago in 1980s, I think Dr. Prakash in Bombay, he started the Indian Society of Sexologists, and I became a member. And that time it was just a ordinary thing, not a very big thing. Only big people will have the experience and the consultation. But I think we don't ask questions. If we ask questions, everybody will have a problem. And you can save many lives and many divorces, especially newly married people, newly married couples. They don't have knowledge. We expect them to have knowledge, but they don't have. And sometimes they come and they say, we will divorce because we are not fit enough. You have one word and your attention will change the situation, and I think we can change the things. Very nice to see all the people, all the good doctors. But when I was reading this, I realized people years before were more intelligent than us. They knew much more about everything. No, when I was reading about flirting, they knew about flirting also. About 2000 years ago. And then we see it's a modern thing or something, everything. They have divided the life, and this Kam Shastra, if you read about how many pages, how many chapters, I think they had a tremendous knowledge. So we are far behind. Dr. Neeraj, I think you should take steps that we also take and we gain more knowledge and more things. Thank you very much.
Thank you, sir.
Thank you so much, sir, for giving us the time. And we can see you are in OPD and it's in busy, and still you have given time and for your kind words. Thank you so much, sir. So next we have a very dear senior, Dr. Sujit Kaur ma'am. Ma'am again doesn't need any introduction. Ma'am is at present the president of the Ludhiana, Jalandhar Society, and she is a very senior consultant, a very busy person, what I can say. So thank you so much, ma'am, for accepting our invitation and for giving us the time. Over to you, Surjit ma'am, for your kind words.
Dr. Neeraj, Dr. Apurva, Dr. Bakshi, Dr. Swarna, Dr. Dhaliwal, Dr. Iqbal, and Dr. Suraj, all the chief guests, chairpersons, speakers, and all the viewers on this virtual platform. A very good evening to all of you. First of all, I should thank Dr. Swarna for remembering the IMS Journal Conference in Jalandhar. That was really a wonderful experience with her. It is a great honor for me to be talking with you today on this very exciting subject about the sexual health. I am delighted to have the opportunity to address such a gathering. First of all, I thank Foxy Health Committee organizers, Dr. Neeraj, Dr. Apurva, for this webinar, for inviting me. It is a great honor for me to be part of this webinar today. Sexual medicine, as we have listened from all of you, this is a much neglected subject. And so many times patient is indirectly complaining of their sexual problems. So it should be discussed with the couple properly, especially in the infertility practices. We have to take the proper history of the couple about their sexual relationships and their problems. So many times it is the cause of their divorces. So this is a very important topic which has been raised by the Dr. Neeraj, and about the sexual health booklet that will be a very helpful book for the gynecologists. This is a great day for you and me. The webinar is going to give us many important take-home points and make us much wiser about this subject. So I convey my best wishes for the success of this webinar. And with this all, I thank you all once and again.
Thank you, madam.
Thank you. Thank you so much, ma'am. Thank you so much. So our next guest of honor is Dr. Saroj Khanna, ma'am. Ma'am is, again, doesn't need any introduction. Ma'am is a very senior consultant from Firozpur, and she is the past president and the patron of the Firozpur Society. So welcome, ma'am. Thank you so much for giving us the time. Saroj, ma'am. Ma'am was there, I think. Saroj, ma'am. I think, sir, I think she was there, but some technical issue. So once he joined, we will get the blessing from her.
Yeah.
So after this blessings, now it's time to start our academic session.
1 minute, 1 minute, Apurva. I have to make an announcement. Sorry to forget to make very important announcement. On 29th, 30 and 31st May, we are having a ICOG certificate course in the sexual medicine. So I request everyone to take advantage of that certificate course from the Foxy and ICOG. We will send you details once everything is final, but it is on 29th, 30 and 31st May. So remember that date. Okay, good.
Thank you. Thank you so much. So I would like to invite my co-moderator, very great senior and friend, Dr. Madan sir, to start the scientific program. And with the change that Shavana ma'am will be first on. Yeah. Over to you, Madan sir.
Thank you, Apurva. We will start with the first session that is on female orgasm dysfunction. And we have the great speaker, Dr. Savana ma'am. And we have 3 chairpersons for this session. First is Dr. Preeti Jindal ma'am, Gitanjali Kaur ma'am, H.K. Chima ma'am. I introduce Dr. Preeti Jindal ma'am. She is IVF and IVF consultant, cosmetic gynecologist and high-risk pregnancy specialist. She is director of Touch Clinic Mohali, General Secretary of Indian Aesthetics and Regenerative Gynecological Society. And Dr. Gitanjali Kaur ma'am is the president of Ludhiana Obstetrics and Gynec Society. And Dr. Chima ma'am, she is the vice principal, professor and head OBGY, and the dean of academics PIMS Jalandhar. I request Dr. Preeti ma'am to introduce Dr. Savana ma'am and start the session. Over to you, ma'am.
Thank you so much for such a beautiful introduction. First of all, I would just like take 2 seconds to thank Dr. Neeraj and Dr. Apurv to give me this wonderful opportunity to be part of this beautiful webinar. And as a General Secretary of Indian Society of Aesthetic and Regenerative Gynecology, I totally understand the importance of sexual health and teaching it to all our gynecologists and audiences. So this is a beautiful webinar, and I'm very happy to know about the certificate course, which is happening in May. And I request everyone to join the certificate course on sexual health. It's very important. And immediately after that, on 29th and 30th of July, the Indian Society of Aesthetic Gynecology is holding a very big conference, annual conference in Chandigarh, for which I invite you all. Now I would like to introduce my lovely friend, Dr. Savannah Chongtham. She is the CMD and founder president of Savannah She Matters Academy. She is senior member of European Society of Aesthetic and Gynecology. Also, she is joint secretary of Indian Society of Aesthetic and Regenerative Gynecology. She is a founder member of ICERC and advisor to FOXY Sexual Medicine Committee. She is a master trainer and she holds many advanced training courses on feminine aesthetics and mommy makeover. And she will also be there during the INSAR conference in Chandigarh in July. So Dr. Savannah herself, she's a urogynecologist and vaginal aesthetic surgeon. And she is also aesthetic gynecology from ISAG, London. And at the moment she is in Kathmandu, and it's so nice, Savannah, that you are there and you are able to join us today. We welcome you, and you please start your session. We are waiting impatiently to hear you. Welcome.
Thank you, Preeti. Am I audible?
Yes.
Am I audible?
Yes, Savannah.
Yes, ma'am, you are audible. You are
okay,
visible.
thank you,
Yeah.
Preeti, for the lovely introduction. I will not waste any time. On the start, I would like to thank Dr. Neeraj, Dr. Apurva, and all the all the members of the Sexual Medicine Committee of FOXY for giving me a chance to be a part of a topic event which is very close to my heart. Yes, I'm in Kathmandu, but then I had to attend whatever Neeraj said. Savannah, you have to talk on F40. I said yes. I knew I was flying to Kathmandu. Just reach hotel. So the connectivity is not very good. So please bear if there is any problem in the connectivity. So to start with, I will be sharing some of my views on female orgasmic disorder. It's getting stuck. 1 second. This is getting stuck. Okay. Is it seen? Hello?
Yes, ma'am, it's visible.
Okay. Now before starting with female orgasm disorder, let's start with female sexual dysfunction. The classification system for female sexual dysfunction in the woman has evolved. Starting a few years ago, we used to talk female sexual dysfunction is a linear categorization of sexual desire, arousal, orgasm, and pain disorders. But now it is more complex and everything is overlapping. We cannot just say this is a desire, this is a dysfunction, arousal dysfunction, orgasm dysfunction, pain disorder. We came to know that everything, each and every part is overlapping with one another. Desire dysfunction is overlapping with arousal. Also, it will overlap with the orgasm. So now since we came to know that each and every this thing is overlapping, the treatment modalities is also becoming a little complex. It has to be multi-modality, multifunctional treatment, approach. We cannot just treat only desire and we can say that arousal and orgasm, we are not bordered. And when I'm talking about orgasm, I need to think about the desire, arousal, pain disorders. Female sexual dysfunction includes a group of sexual complaints and disorders affecting women of all ages and stemming from a heterogeneous array of etiologies and contributing factors which is overlapping. Personal distress is a key factor in defining a sexual problem as a dysfunction. As a cosmetic gynecologist, we work towards treating her unspoken problems, her hidden problems. So sexual problems are one of the major causes which gives rise to her hidden problems. And in the Indian scenario, a woman will not come out in the open and say that this is I am having arousal, this is orgasmic the disorders, I am not getting any orgasm. There are very, very few people who will come out in open and say, but we need to identify it from many problems which come under present to us in DSM-4 diagnosis and the DSM-5. Now, so many of the criteria, these things has been changed definitions, but female orgasmic disorder has remained same. So there is a complex pathway after orgasm. Orgasm, we will talk about. Hello?
Hello, Savannah, we can hear you. Savannah, you are mute. Savannah, please unmute yourself.
No, there is some problem in the connectivity. I'm logging in from the hotel Wi-Fi. There is some problem in the connectivity. Kindly bear with me. The complex pathway orgasm. What is the most important factor in the sexual act is the brain. But for the orgasm, it is coming from all the pathways. From the glans clitoris, it comes to pituitary nerve to the sacral plexus. We have the clitoral complex, Z-spot, which is coming to the pelvic nerve. Cervix, say, it's coming to the hypogastric, vagus, and oxytocin, intravaginal, other uranus, John, anus, rectum, nipple, etc. All the parts are sending signal to the brain, and which is giving rise to the orgasm. Definition of the orgasm is a sensation of intense pleasure, creating an altered consciousness state accompanied by pelvic, striated, circumvaginal musculature and uterine anal contractions, and myotonia that resolves sexually induced vasocongestion and induced well-being contentment. Orgasm can be defined as a sum of all physiologic events that happen in the body during the sexual climax and the individual experiences of them. The female orgasmic disorder, this is the persistent or recurrent delay in frequency or absence of orgasm or markedly diminished intensity of the orgasm despite adequate, this has to happen despite adequate sexual stimulation on all or almost all occasions of sexual activity, and significant distress to the individual, which is very, very important, which causes significant distress to the individual is very, very important. Diagnosis based on the clinician's judgment, which is based on age, sexual experience, partner compatibility, time and the place. The time and the place is a very important factor in a sexual act, because we have to give this one proper place, proper time for the couple to enjoy the sexual act, and also for them to escalate to the orgasm. Again, is getting stuck. Okay. In most of the studies of MRI, and please excuse me, the hotel network is very, very bad and I'm having problems in playing the PPT. Most of the studies of MRI and PET investigating female orgasms, single stimulus from only one focus is studied, as it is mostly the clitoris. However, today we know that female orgasm develops through different pathways and the stimulus of the different loci.
Savannah, you can switch off your video, so it will be easier.
I think I must. Okay.
Switch off your video, then it will be fine.
Cannot switch off the video, already stuck.
Okay.
I cannot switch it off.
Okay. Go on.
Okay. Please bear with me. Physiological blood vessel damage, spinal cord lesions, or damage to the nerves in the pelvic region. Medications side effects. There can be side effects of the medications: antipsychotics, antidepressant, narcotics, substance abuse, and the most important, FGM. Nowadays, we have started cosmetic gynecology. Even I myself am giving training, and so many people started doing cosmetic gynae procedures without proper knowledge of the procedures. One of the cosmetic gynae procedures, what we do is clitoral hood reduction or clitoral hoodectomy. The very purpose of clitoral hood reduction and clitoral hoodectomy is to give sensation to the clitoris, to the woman. So now when we are doing clitoral hood reduction and hoodectomy, the incision has to be very, very, very superficial let me specify, it has to be very, very, very superficial. If it is done by an inexperienced person, if the incision is little deeper, then all the nerve endings are destroyed. So it's one of the, so I would request all the upcoming cosmetic gynecologists or whoever, everybody who has been practicing cosmetic gynecology, energy-based devices are okay, but going into the surgical, especially clitoral hood reduction and hoodectomy, please be very, very, very careful. Instead of doing good, we will be harming the lady by destroying all the nerve endings. Okay, psychological past sexual abuse, rape, incest, trauma, emotional abuse, fear of becoming pregnant, fear of rejection by the partner. Sometimes women feel, if I have orgasm, if I come, what will my partner think? My partner may think I am a bad woman. He may think that I must have had lots of sexual experiences before. So sometimes people say, when they are coming for existing counseling, when we ask, what happened? The lady, they will not talk in front of the partner, but they will come and say, Madam, if I enjoy, if I show that I'm having orgasm and I'm enjoying, then my partner may think I'm a bad girl. So many things are there. Also, emotional non-attachment. The sexual cycle for a male is different from the sexual cycle for a woman. For a man, with due respect to all the gentlemen present, for a male, it is just one spike and a down. This is what we learn from, I'm not a male, so I will not know, but this is what we learn from the theory. But for a woman, the graph is totally different. It has to go up gradually, and also once it has to go down gradually. The gradual going up of the graph is very, very important for the woman to have orgasm and to have full sexual satisfaction. Stress, guilt, religious or cultural belief, mental health issues. So there is I'm really having problem with my PPT. Anyway, let me try. Orgasmic phase, it's a cerebral response. It's the shortest phase, very few seconds, sudden release of sexual tension, BP, then respiratory rate, intake of O2 are at its peak. Involuntary muscle contractions all over, especially of feet, uterus, vagina, and base of the penis. One of the most powerful emotions you may know of, supreme bliss and ecstasy. Explosive neuromuscular response at the peak of the sexual cycle. Now the orgasmic phase, there is a correlation with the tantric sexuality and orgasmic phase. Those people who do tantric sexuality, tantric sex, they use the orgasmic peak for attaining so many things. This is another bigger chapter, tantric sexuality. If we have time, we will do. Nearest we should do some other this thing about the tantric sexuality and Indian sexuality for some other webinar. So orgasm is one of the most important factor for the tantric sexuality, what the tantrics used. Diagnosis for a minimum duration of approximately 6 months. The sexual dysfunction is not better explained by a non-sexual cause. Just because they are having mental disorders, severe relationship stress, other significant stressors, substance medication, other medical conditions, we cannot just say that this one is having orgasmic disorder. Primary and the secondary, as the name suggests, primary is the woman is at first, they have not had any orgasm at all. Secondary is they have had, but for some reason, maybe FGM or any other trauma or stress, they are not having at the moment. Prevalence is around 24% of the women cannot achieve orgasm. This is the prevalent. Okay. Quantitative, we have many these things about measurement, quantitative measurement, didactic measurement. My PPT is not working very properly, so I'm going to skip the slides. Physical examination, these are available on the this thing. So okay. A general physical examination is necessary before we come to any other this thing. We have to do a general physical examination, careful cardiac and neurologic examinations. Pelvic examination is very, very important to see any genital malformation, dyspareunia, any burns, any tumors, or any cuts in the vaginal area. And measurement of genital sensory function is very, very important. Tactile, vibratory, temperature perceptor thresholds, clitoral sensitivity have to be monitored. Then vaginal pH, local vascular functions, assessment using platysmography, Doppler USG has to be done. Or the routine blood test has to be done, CBC electrolytes, blood urea nitrogen, creatinine glucose, everything. Vitamin B12 is again very, very important. Vitamin B12 in the folate levels. We must know that orgasm is mainly on the sensory. So from the nerve endings, the nerves has to be very, very good. So vitamin B12 in the folate levels may give to a peripheral neuropathy. We may be looking for so many other reasons. At the end, we find out this one is suffering from peripheral neuropathy. Diabetes, again, we rule out long-standing diabetes. Urine analysis for any infection, glucosuria, lipid profile has to be done. Hormone testing, thyroid, estradiol, FSH, LH, prolactin, testosterone has to be done. Okay, and psychosocial intervention is very, very important. Sex therapy techniques has to be done. Primary orgasmic disorders are more likely to get treated. So we have to counsel the patient on directed masturbation, sensate focus exercises, exposure therapy are required. I am not going to into detail. Sensate focus exercise goal is to orient the partners towards attaining sexual pleasure rather than orgasm. We need to teach them orgasm is momentary, and also you need to build up the sensual pleasure, build up together. Clinicians' basis for education and treatment planning, a series of home exercises to increase the partner's comfort with sexual intimacy. Partners exchange pleasurable touches of areas of the body other than the private parts. We should teach them. We should teach them touch some the hands of each other. You touch the hand, feet. Just see whether you get any arousal. In subsequent sessions, gradually touching of private parts. In the starting, they should not just jump to the private parts. So intercourse is not recommended until the final stage of the treatment is over. Is a long distinct stage. Treatment, exposure therapy, it is used as a component of multimodal cognitive behavioral therapy. Graded exposure to anxiety-provoking stimuli aims to increase the patient's comfort with and reduce the avoidance of fear experiences. Construct a list of progressively anxiety-provoking scenarios that are personally relevant, starting with the least challenging scenario until the stimulus no longer evokes strong anxiety. Then couple therapy is important. Partner communication therapy, partner communication training is very, very important. Drugs, sildenafil is used, topical vasodilators are used, intranasal oxytocins are used. But now with the distinct of Kegel exercise are used, but which this one with the starting of cosmetic gynecology, with the cosmetic gynecology in the field, we do lots of treatments for female orgasmic disorder. Female orgasmic disorder, from the cosmetic gynecologist point of view, we divide into vaginal orgasm and the clitoral orgasm. For the vaginal orgasm, we give Z-spot identification. This is first described by Raffenberg, located inferior to the urethra, midway between the pubic bone and cervix, 1 to 3 inches between opening and urethra, responsible for vaginal orgasm. So this is the vaginal approach. Then we have the urethral approach also, but I do not use urethral approach as such also, and I do not recommend. This is the picture, beautiful picture of this thing after Z-spot has been given. Augmentation, we use this one pre-fill hyaluronic acid syringes. We give and look at this 0.1 on each side. Clitoral hooding, since here we can see that the clitoris is completely hooded. So clitoral hooding, we need to remove this. Either we do clitoral, this one, hoodectomy or hood reduction. I do both. I prefer hoodectomy. I hope the video plays. Okay. This is a short video of the clitoral hoodectomy. Hoodectomy, and okay, this is a here we need to see the skin, with the incision has to be very, let me stress again, very, very superficial, so as not to injure the nerve endings. Okay, this is one thing. Clitoral, this one, hoodectomy. The patient, I had warned the patient that after doing clitoral hoodectomy, there is chances of forming micropenis, but she did not listen. This is the chance. This is this thing about having micropenis. This is not again a very good situation. The patient will get stimulus throughout the day. So it is not a very pleasant situation. But this one, I have warned the lady, I do not want to do clitoral hoodectomy for you, but she had insisted she wanted this.
Sorry to interrupt, Savannah. 5 minutes left, so please finish in 5 minutes.
Yeah, I finished. And this one for the O short has been patented by Dr. Charles Tunnell. I cannot talk about this O short without this one mentioning Dr. Charles Tunnell's name. O short is given. PRP, platelet-rich plasma, is given in the frenulum of the clitoris, and which enhances the function of the clitoris. I do conduct this one personal mentorship program in Imphal. In the C matters, I have opened at the moment 5 to 6 franchises. But in my this one headquarter, I do conduct aesthetic gynecology, which is certified by Asian Academy of Feminine Aesthetics. Also, we give additional certificate from American Academy if required on demand. These are the machines that I have. Okay. Conclusion: sexual problems are widespread in society and are influenced by both health-related and psychosocial factors. Present with a complex combination of problems requires a comprehensive assessment, and a thorough biosocial history should be taken. Diagnosis is based on the clinician assessment. Thank you.
Thank you, Savannah. It was a beautiful talk.
I must apologize. The PPT was horrible.
No, it was perfect. No,
it was good. It was very good. So over to other chairpersons for any comments. It was a beautiful talk. Thank you, Savannah.
Yeah, I wish to say something. Congratulations, dear Dr. Savannah. As beautiful you are, so similarly, the slides were also very beautifully depicted and very meticulously planned and very, extensively studied. The topic and videos were very nice. And I wish to add certain points that according to Diagnostic and Statistical Manual of Mental Disorders, as you have already given its reference of the 5th edition, it is very nice to add that if the patient is complaining of FOD of more than 6 months, that should be included. And another point has been added in the definition that if the feeling is of more than 75% of FODs, then we should include it as a FOD. And to add on, you talked very nicely about primary orgasmia and secondary one. And as a gynecologist, I wish to comment that certain things which are pertaining to dyspareunia, that they should be taken care of: recurrent vaginal infections and chronic endometriosis and hypogonadism. And one very important point: the postmenopausal women, sometimes we need to give HRT, the new modality with low doses. They are available to take care of the secondary orgasmia, to take care of that particular part, because in menopausal women sometimes secondarily they face these kinds of problems. And when we talk of the counseling should be individual, and the couple counseling in individual, the confidentiality of the counseling is very mandatory. That should be maintained. And the relationship issues, the relationship crisis, the unsolved, the sexual partners, unresolved issues, any past history of physical or emotional abuse, they have also to be taken into account. Otherwise, a very well presented case. My bundles of congratulations and my appreciation to the organizing team. And thank you, Dr. Neeraj, for adding me as a chairperson, and nice to be a part of your family. Thank you.
Thank you, all the chairpersons, for your kind inputs. Thank you, Savannah ma'am, for great talk.
Thank you so much.
Yes.
I had please, I need a permission to leave, because as a operating faculty, we have some pre-congress meet. So please, usually I do not just run off after my talk, but please excuse me.
Okay. Thank you, ma'am. Yeah. Over to you, Dr. Apur, for
Yeah.
next session.
After this wonderful talk, now it's the time to start our second talk. And for chairing the session, I would like to invite Dr. Sarabjit Kaur, ma'am. Ma'am is at present the Secretary of the Firozpur Society. Thank you so much, ma'am, for joining. Next is Dr. Vaneet Kaur, ma'am. Ma'am is the very senior consultant of Ludhiana at Salvi Hospital. And next is Dr. Har Poonam Mankum, ma'am. Ma'am is the professor at the Amritsar Government Medical College. So welcome to all of you, ma'am. And thank you so much for accepting our invitation. I would like to invite the Sarabjit Kaur, ma'am, to introduce the speaker, Dr. Dalpreet Sindhu, ma'am. I think Sarabjit ma'am is not there. She informed me that she might be in traveling. So I would like to invite Dr. Vaneet Kaur, ma'am, to please invite ma'am. Dr. Dalpreet Sandhu, ma'am. Vaneet, ma'am.
Good evening, everyone. I would like to invite Dr. Dilpreet to present her talk. And we all know as sexual medicine is upcoming, but we as gynecologists, it is our duty to sensitize everyone around us to have a proactive approach in this field. We know as Indian women are quite shy in discussing their problems, and many times they hint at presenting with some other kind of a symptom. The issue basically is underlying a sexual dysfunction. I know Dilpreet personally. She's a very hardworking and committed gynecologist working in GMC Chandigarh. And now I would like to invite her to present her talk.
Thank you, ma'am.
Nice to see you.
Nice Same here, ma'am. Ma'am is my ma'am in real sense. I've worked under them in CMC Ludhiana for I guess 3 or 4 years. I'll share my screen. Thank you, Neeraj sir, for giving me the opportunity. Are my slides visible?
Yes, just make it.
Yes,
it's visible.
Yeah, perfect.
Good evening, everyone, my respected seniors and dear friends. I'm going to talk on female sexual interest and arousal disorders. So first of all, there are various kinds of sexual disorders. As enumerated in this slide, we are going to talk on, I'm just adjusting my screen.
Now we can see
so out of these, right, sir. For the first one, the problems with the low sexual interest and desire disorders. This condition is highly prevalent. As per various studies, around 40% of women in US and Europe are found to be affected by this condition, and 11% have reported distress also because of this. Why this is important to discuss this issue? Because it has profound effect on women's quality of life, overall health and well-being. Diagnostic criteria, DSM has merged two conditions, female hypoactive sexual desire disorder and arousal disorder, under this common entity which I'm talking right now, that is female sexual interest and arousal disorders. What is the reason of overlapping? Because these two conditions, they often coexist, and their diagnostic screening is almost same, and the treatment of one improves the other condition also. So what are the criteria for the diagnosis of female sexual interest and arousal disorders? Out of these points, 3 out of 6 should be met, which include absent or decreased sexual interest, erotic thoughts or fantasies, initiation of sexual activity or responsiveness to the partner's attempts, excitement and pleasure during the sexual activity is reduced, arousal in response to the sexual cues and sensation during the sexual activity is reduced or absent. And the women must be experiencing it more than 3/4 of the times during the sexual encounter, and with the notable exception that she is not under the influence of any substance or medication at that time. Minimum duration for the making diagnosis is again 6 months and deemed to be causing significant distress. ICD-11 also stresses upon all these factors, and distress is a main component for making the diagnosis of HSTD or IAD. Coding of these two separate entities merged together now is still separate under ICD, latest ICD coding. So to classify the sexual interest and arousal disorders, they can be primary or secondary to some cause, acquired during the recently, or maybe lifelong, right from the beginning, and they may be generalized or situational to some partner, or maybe to the self-stimulation or with particular partner. So to explain the women's desire for the sex and sexual response, there is a biopsychosocial model which integrates various components for understanding the HSDD, which includes psychological aspect, her interpersonal relationships, socio-cultural factors like upbringing and the cultural norms, and biology, including her own neuroendocrine system. Neuromodulators play an important role in the sexual stimulation. Various excitatory pathways include dopamine, norepinephrine, melanocortin, oxytocin, estrogen, testosterone, and the inhibitory, the primary one is serotonin, opioids, and various other ones like prolactin. This serotonin, this neuroinhibitor, it restricts the excitatory systems and it is activated during the periods of sexual inhibition. Brain also plays an important role. There are various arousal centers and various centers involved in the cognitive processing. So hypofunctional, less excitation and more inhibition, or both, may impair vaginal vasocongestion, lubrication, and hence affects the desire and orgasm. There is one study, vicious study, which was published in 2006, which said that HSDD, the prevalence is around 9 to 26%, with a higher incidence in surgically menopause women and in the age group 20 to 49 years of old category. All of these, these women were found to be significantly lower on 7 out of the 8 domains on the health assessment form also. And another study is PRESIDE in 2009. It was a large study conducted on more than 31,000 women. Again, the prevalence was found to be around 38% in the age group of 45 to 65 years of age group. And both of these studies, they said that women with HSDD were found to have poor health status and quality of life. They were having a greater overall health burden and twice likely to have various kind of comorbidities as compared to the women with the normal sexual desire. So more profound effect on their mental health as well as the psychosocial parameters, both in the premenopausal as well as the postmenopausal women. So now, how to diagnose this? What are the various times and where we can ask the women and diagnose this? Annual physical examinations are the good opportunity to ask this, but 45% of women said this topic was on the sexual health was not raised during their visits. And another study says that around 80% women reported they never mentioned their desired problems to the healthcare providers, and only 1/3 were formally discussed their problems with the healthcare providers. So both of these surveys say that embarrassment contributed to the women's unwillingness to seek help from the healthcare provider. And another barrier is low sexual desire. It increases with the age and the related distress decreases. So the overall prevalence of the HSDD remains throughout steady in the adult lifespan. The reason being, women believe that it's simply a part of aging, so they don't seek treatment for this as it increases with the age. On the part of healthcare provider, what are the barriers? Same, first one is embarrassment, another is they are inadequately trained, so they have a lack of confidence in diagnosing and treating HSDD. And when one very important aspect is time constraint in a routine OPDs. So how to screen for HSDD? We should ensure a safe, non-judgmental environment for the patient, and we should ask open-ended questions. And we should consider all the words, basic words, what she is using in her conversation, like bother, which may be the simple word, but maybe the indicator of underlying her frustration, grief, guilt, incompetence, all those things. So our busy routine can be overcome by this simple screening method, that is decreased sexual desire screener, in which the screening can be accomplished in a time-efficient manner during an office visit. This is a 5-item self-reported questionnaire, helps in detecting and diagnosing HSTD. It's a validated tool even for the non-specialized healthcare providers. First 4 questions. If all answers are yes, means she is a case of HSTD. In past, was her level of sexual desire or interest was good as compared to now? Has there been decrease in her level of sexual desire? Is she bothered by these symptoms? Would she like to her level to increase? If all are yes, means she is suffering from HSTD. And 5th question is the various component looking for the cause of HSTD. If all are no, means it is a primary HSTD. If any answer is yes in the 5th, means by addressing that issue, her HSTD may be treated. So it is secondary to that particular cause. So that simple is the screening tool. So how to evaluate the case? We should try to recognize the underlying condition that is contributing. So most important is the relationship or the physical issues. So more detailed information related to the onset, duration, her behavioral adaptation, or is she avoiding that particular her partner, or the level of distress, what is the level of distress that she is having. Close evaluation of her medical history, any comorbid condition, use of any over-the-counter medication. Complete gynae history is very important, which includes any sexually transmitted diseases, history of sexual abuse in the past, urinary or bowel complaints. Simple incontinence in these urinary or bowel may be the cause of her low desire. Prior surgery, which may be causing adhesions and she may be having painful sexual activity. Psychiatric disorders, if she's suffering from depression or anxiety, may be the important contributing factor. OCPs have also been associated with low desire in some studies. Targeted physical examination as indicated, and specific test based on her history and physical examination like thyroid and prolactin testing. Pelvic examination is highly recommended to look for any occult organic cause, physical factors, or unknown comorbidities like endometriosis. Lab investigations, again, depending upon the case individualization, particular tests should be ordered to treat her modifiable factors. She should be referred to a specialist if there is a contributing comorbid disorder that is complex. She is having lifelong sexual disorder, some anatomical deformities found. There is a history of physical or psychological trauma, and treatment failure at first level has occurred. So depending upon that, to the specific specialist, depending upon the cause, she should be referred. This is a summary. Look for whether primary or secondary, and then treating the cause. Now coming to the management mode. Biopsychosocial approach for the treatment of women is warranted, and treatment is multifaceted, so should be individualized depending upon the case individualization. First, the initial approach at every level is office-based counseling to provide her basic education on the how we have made the diagnosis and what is she suffering from. Correcting her misconceptions about the human sexuality, and recommendations for behavior or lifestyle changes to improve her self-esteem, to increase her sexual interest and intimacy between the partners. Using implicit model, which is most acceptable one, and then a stepped approach towards for the general health care providers should be followed. Goal of her treatment is to improve her quality of life and creating a positive environment for a healthy, fulfilling sexual life and her satisfaction level. Secondary causes, if are found, then treating the main cause that is hindering her sexual desire, like vaginal dryness, vaginismus, if there is any local infection, comorbidities, psychological issue, or there may be some morbidity in the partner also. So we should treat the cause in the secondary cases. coming back to the psychological intervention, refer to the psychotherapist is the next step once the office-based counseling proves inadequate. Addressing her, first is the cognitive aspect. Psychotherapy is a recognized treatment strategy for HSTD, typically focused on modifying her thoughts, beliefs, behavior, emotions, relationship issues that are interfering with the desire. First one is sensate focus. This is a sex therapy technique introduced by Masters Johnson team. It works by refocusing the participant on their own sensory perception, sensuality, instead of goal-oriented behavior focused on the penetrative sex. Second one is cognitive behavior therapy. It focuses on altering thoughts and behaviors that are distracting her or resulting in the inhibition of the sexual thoughts during the sexual situation, with a specific focus on automatic thoughts and beliefs. Mindfulness. This is non-judgmental, present moment awareness. This is to encourage participants to connect and engage with their sexuality by learning and participating in various mindfulness exercises. Next is the pharmacotherapy. There are certain drugs predisposing, causing HSTD, which should be avoided, and the second ones are drugs used for the treatment. First one is the drugs causing HSTD, various drugs like anti-epileptic, certain cardiovascular drugs like ACE inhibitors, NSAIDs, opiates, antipsychotic drugs, and substance abuse are known to be causing low sexual desire in both genders. So the treatment part, first one is flibanserin. The dose is 100 milligram at bedtime. This is serotonin receptor modifier agonist and antagonist at various different type of receptors. It results in decrease in the serotonin activity and increase in the excitatory neuromodulators that are dopamine and norepinephrine. It should be used with caution with certain enzyme inhibitors, like commonly used ones are ketoconazole, ciprofloxacin, fluconazole, erythromycin, and drug inducers like OCPs and fluoxetine. Ingestion should be delayed if she has consumed alcohol, at least for 2 hours. There should be the gap, and patient who consume 3 or more alcohol beverages is advised to skip the dose of flibanserin. Testosterone is the next therapy. This is evidence-based off-label treatment for perimenopausal and postmenopausal women HSTD. Transdermal patches and gel is available, and various RCTs have shown the positive effect of testosterone on all aspects of the sexual response. But it should be used with a caution, because it may cause breast cancer, hepatotoxicity, acne, hirsutism, clitoromegaly. So minimum dose for minimum effective duration is the principle. Bispirone is serotonin 1A partial agonist. Actually, it is approved for the anxiolytic as an anxiolytic drug and used off-label for HSTD. Dose is 30 to 60 milligram per day. Bupropion, it acts on norepinephrine and dopamine receptors. Dose is 300 to 400 milligram per day. This drug has long-term available safety data, risk and side effects all well characterized, and the cost is also low. It should be dosed in the morning, and patient is observed for increased anxiety, insomnia, hypertension, any kind of side effects, tremors, dry mouth. The next drug is bremelanotide. This is US FDA approved to treat acquired generalized HSTD, got approval in 2019, but it is associated with fetal harm in animal studies. So patient must use effective contraception and should not be used in the infertility patients having low desire who are planning to conceive. It activates melanocortin receptors. Patient injects this under the skin of abdomen or thigh 45 minutes prior to the anticipated sexual activity, and may later on optimize the timing based on any side effects like nausea, etc., and should not be used more than 1 dose within 24 hours and not more than 8 doses in a month. And patient should discontinue treatment after 8 weeks if no improvement in the sexual desire or associated distress is noticed. Next is Tebolon, actually used for treating the climactic complaints. It also enhances the mood and sexual well-being and also treats vaginal atrophy. DHEA levels are found to be low in the morning samples of DHEA as well as cortisol, so supplements seem to be promising. And positive results have been found at the dose of 100 milligram per day. Probably it gets metabolized into the testosterone. Other drugs are nitric oxide donors like sildenafil and L-arginine, and combination of testosterone with sildenafil and bispirone are also available, found to be more effective, but side effects also increase with the combinations, including mild flushing,
Ma'am,
headache.
sorry to interrupt. Yeah, already over the time.
Almost
So
already done. It's covered.
okay,
And
thank you so much.
lubricants, laser therapy, oxytocin, and cycloserine are also mentioned in literature. And understanding normal aging, there may be need of longer foreplay and alternative forms of intimacy may also be tried. So to conclude, personal distress is essential for the diagnosis and the treatment. Psychotherapy is the main, and we also have various pharmacological options for the treatment of sexual interest and arousal disorders. Thank you.
Thank you. Thank you so much, ma'am. Your lectures are really always an eye-opener, entertaining to all of us. So I would like to invite Vaneet Kaur ma'am and to Harpuna Manku ma'am to have their comments and any questions. Yeah, Vaneet
Thank
ma'am.
you. Thank you, Dr. Dilpreet. It was an excellent presentation. Just one comment I would like to make, because since annual health checkups is not a routine practice in India, so I think we should focus, as Dr. Lakveer Dhaliwal suggested, we should devise some simple screening questionnaire which we can give to a woman during whenever they report our OPD. That is because all of us usually face this time constraint, and sexual health inquiry sometimes becomes difficult. So questionnaire definitely is going to help us in solving these issues. Thank you.
Anji. Am I audible, Dr. Harpunam?
Yes, madam. Yes, ma'am, you are audible.
Yeah, first of all, I would like to congratulate Dr. Dilpreet for such a nice and entertaining, and it was a complete lecture. She had stressed very well on the classifications and the diagnostic criteria. Regarding the treatment, of course, I would like to add that although these drugs are there and the patients, I will say the woman, not the patient, they are using these, but the side effects are too many. And of course, I don't think they are usually very effective also. But of course, most of the problems, they are usually psychological, and maybe a proper psychotherapy will definitely help. Thank you so much. It was definitely a very
Thank you so
good
much to the chairperson. Thank you so much to the speaker. So I would like to invite my co-moderator, Madan sir, for the next talk. Madan sir, over to you.
Thank you, Apoorva. We will move on to session number 3. It is on vaginismus, and we have got the speaker, Dr. Sindhu Lakshmi ma'am, and the esteemed chairpersons, Dr. Pooja Darwal madam, who is senior gynecologist at Government Hospital, Firozpur, and other chairperson is Dr. Neelam Sode ma'am, who is the senior consultant gynec from Ludhiana, and third one is Dr. Sukriti Sharma. I welcome Dr. Pooja ma'am, and would like to invite to introduce the today's speaker. Over to you, madam. Pooja madam.
Thank you, Dr. Madan. Hello, good evening, everyone. First of all, I will like to thank Dr. Neeraj Jadhav and Dr. Apoorva Datta for making me part of this neglected topic, that is the sexual health. Without wasting our time, I will like to introduce our next guest speaker. She is having 8 years of experience, Dr. Sindhu Lakshmi. She is MS in OBG with fellowship in high-risk pregnancy and perinatology and cosmetic gynecology. She is consultant in maternal fetal medicine and cosmetic gynecology and NJ Hospital, Mysore. Also, she is working as OBG specialist at Ayushmati Clinics under National Health Mission. I feel elated to invite you and introduce you, Dr. Sindhu. Please join us. Over to Dr. Sindhu.
Thank you, ma'am. Good evening, respected. Ma'am, thank you, ma'am. Can you hear me, ma'am?
Yes, you are audible. Yes, you are audible, ma'am.
My screen, yeah.
Sindhu ma'am, please make it full screen.
It's not moving in full screen. Yeah, it's
Yeah,
moving.
and then yeah.
Thank you. Yeah.
Yeah.
Thank you, ma'am. Thank you for that introduction. Good evening, respected seniors and my dear colleagues. I thank Foxy, the sexual committee members and members of this forum for providing me this opportunity to talk in this webinar. I have divided the topic vaginismus on the following headings: classification and definition, prevalence, types, etiopathogenesis, clinical features, Lamens grading, evaluation and treatment of vaginismus, and ultimately summary. Now, classification of female sexual dysfunction according to the Diagnostic Statistical Manual of Mental Disorders, 4th edition, groups it into 3 categories: sexual arousal or desire disorders, orgasmic disorders, and sexual pain disorders. The DSM-4 categorizes vaginismus and dyspareunia as sexual pain disorders. So earlier, we see that vaginismus was defined as recurrent or persistent involuntary spasm of the outer third vaginal muscles that interferes with sexual intercourse by preventing penetration and is associated with increased distress or interpersonal difficulties. The DSM-5 has made few minor changes, and it identifies vaginismus and dyspareunia as vaginal penetration disorders or genitopelvic pain penetration disorders. Just a brief note on this genitopelvic pain penetration disorder. As catalogued by DSM-5, the genitopelvic pain penetration disorders are defined as persistent, recurrent marked difficulties with one or more of the following. That is, there should be difficult vaginal penetration during intercourse or penetration on at least 50% of the attempts. There may be marked vulvovaginal or pelvic pain during at least 50% of vaginal intercourse or penetration attempts. Marked fear or anxiety during at least 50% of vaginal intercourse or penetration attempts. Marked tensing or tightening of the pelvic floor muscles during attempted vaginal penetration on 50% of the occasions. Now, these symptoms must be present for at least 6 months and cause clinically significant distress. However, they should not be explained by any non-sexual mental condition or as a consequence of any severe relationship distress, nor should be attributable to the effects of a substance, medication, or any other medical condition. So as per the recent consensus, vaginismus is defined as the persistent or recurrent difficulties of the women to allow vaginal entry of a penis, a finger, and or any object despite the women's expressed wish to do so. The true prevalence of vaginismus in the population is difficult to assess, since such studies would require gynecological examination that patients prefer to avoid. Vaginismus affects approximately 0.6 to 7% of the females worldwide. However, in the clinical settings, the incidence may be as high as 5 to 17%. Moving on to the types of vaginismus, the primary and secondary. Primary is a lifelong condition wherein the lady will never be able to have an intercourse. The spasming begins when the person tries to have sexual intercourse or insert an object like a tampon into the vagina. It's very difficult to undergo a gynecological examination. Sometimes it has to be done under IV sedation. Secondary acquired vaginismus develops after a person has experienced the expected sexual penetration without any difficulty, and this can occur at any stage of life. Usually stems from a specific event such as infection, a medical condition, surgery, childbirth, or menopause. Another classification is global vaginismus and situational vaginismus, which can be further divided into primary or secondary. In global vaginismus, the symptoms occur in response to any type of penetration. So the lady is unable to place anything in the vagina. Situational vaginismus occurs in response to some types of penetration. So she is permissive for few occasions like gynecological examination or tampon insertions, but she cannot have an intercourse. Moving on to the etiology, vaginismus was first described by Dr. J. Marison Sims in 1862. There is a consensus that vaginismus is a psychophysiological disorder with phobic elements resulting from actual or imagined negative experiences with sexuality or penetration and or organic pathology. Fear and anxiety concerning penetration is expressed physiologically via the involuntary muscle spasm that characterizes vaginismus. The various etiological factors are classified into organic causes and inorganic causes. The organic causes can be further subdivided into congenital causes or abnormalities like hymenal abnormalities or vaginal atrophy, irradiations, infections like STDs, genital herpes, warts, PID, trauma. It can be an obstetric trauma or any mechanical injury causing painful scars, atrophic vaginitis as seen in postmenopausal or estrogen deficiency states, pelvic congestion as seen in PID and endometriosis, pudendal neuralgia, miscellaneous like pelvic organ prolapse, tumors, and malignancy. Now, the organic pathologies may lead to painful attempts at penile vaginal intercourse, which can lead to spasm of the muscles. Now, this has been postulated that the spasm may be an appropriate initial response to an understandably painful stimuli, but continues as a conditioned response even when the primary problem is resolved, resulting in vaginismus. Comorbidities like diabetes, multiple sclerosis, or spinal cord injury are also associated with vaginismus, probably because of poor lubrication and decreased vaginal laxity. Moving on to the non-organic causes, fear of pain is one of the primary reasons. Secondary to fear and anxiety, it may cause a defensive contraction of the perivaginal muscles. This is involuntary and uncontrolled and functions much the same as any reflux to avoid injury. A variety of childhood experiences has been implicated for the development of this fear of pain. A history of sexual abuse at a young age is seen 2 times more common among vaginismus patients. Childhood physical trauma such as enemas and suppositories, fear of violent father, negative maternal conditioning are also associated with vaginismus. Negative perspective over sexual activity. Experiencing or witnessing a sexual trauma is a casual factor in the development of vaginismus. It's also observed when the parents' relationships were poor and actually violence or physical abuse occurred between the parents. Many of these women with vaginismus had witnessed or heard their mothers being forced to sex. Strict religious orthodoxy, fear of pregnancy, fear of childbirth, or fear of AIDS, STDs are also causes of vaginismus. Misinformation, ignorance, and guilt about sexuality. 90% of the vaginismus patients shows a high degree of ignorance and misinformation regarding their sexuality. In a study of vaginismus patients, it was observed that 67% were being brought up to believe that sex was wrong. Women with vaginismus generally experienced shame, disgust, and dislike towards the genitals. And these feelings and misinformation are learned from mothers who also disliked their own genitals or disliked sex or even had vaginismus. Sexual guilt was a result of deep sexual conflict, leading in turn to fear of punishment and even stronger physical defense reaction. Personality. Studies have shown that women in unconsummated marriages use a variety of defenses to deal with the conflicting emotions about sexuality. These defenses subsequently became a part of their personality. Male partner's personality. Now, the males can potentially cause or exacerbate vaginismus in the female partner by being either undercompetent or over-anxious. It has also been seen that sexually secure husbands might even overcome mild degrees of vaginismus. Strained couple relationships, that is infidelity or conflicts, are also associated with vaginismus. Moving on to the clinical presentation, most of these cases present as unconsummated marriages, and they may be diagnosed while evaluating for gynecological complaints or primary infertility. Lament classified the severity of vaginismus based on the patient's history and behavior during a gynecological examination. There are 4 grades, where grade 1 is the mildest form and grade 4 is the most severe form. In grade 1, there is spasm of the levator ani muscles, but with reassurance, patient is able to relax enough to have a gynecological examination. Grade 2, there is spasm of the levator ani muscles, but the patient is not able to relax, but still a gynecological examination can be done. In grade 3, in addition to the spasm of the levator ani muscle, she starts elevating her buttocks and avoids a gynec examination. Grade 4 is the most severe, wherein she retracts and adducts her thighs with dorsal arching, and examination cannot be done. Pasek added another grade of vaginismus wherein the lady manifested with visceral responses such as crying, shaking, trembling, sweating, hyperventilating, experiencing palpitations or nausea, vomiting, going unconscious, wanting to jump off the table, or also sometimes wanting to attack the doctor. Effects of vaginismus. Now, this stresses the importance of identification and treatment of vaginismus. Now, vaginismus causes significant personal distress to patient and her partner. It is also a predisposing factor for many anxiety disorders. Primary vaginismus is the predisposing factor to dyspareunia. Divorce is a common outcome for many of these patients. Male partner developing sexual dysfunction like erectile dysfunction, premature ejaculation is seen more common when the lady has vaginismus. Diagnosis. Careful history and unhurried methodical examination is very important. Make the patient feel comfortable, avoid any embarrassment, ensure privacy, assure confidentiality, be non-judgmental, allow sufficient time. Sometimes multiple sessions are also required. At consultation, it's very important to greet the patient and give a small self-introduction. Be polite. Body language is the key to eliciting the history. Body language expresses respect, empathy, and genuineness. Maintain eye contact, give full attention, listen and take notes. Avoid distractive actions. Do not interrupt. Avoid yawning, raising eyebrows, narrowing the eyes, looking at the watch or mobile, or changing the tone of the voice. A detailed history taking is important in evaluation. Here, history of concepts and beliefs and influences should be asked for. History of any phobias, that is fear of pain, fear of pregnancy, fear of HIV or STDs should be elicited. Family, religious or cultural background should be elicited. The level of sexuality knowledge, irrespective of the educational status, should also be noted. Past traumatic experiences, that is history of sexual abuse or rape in earlier part of the life, or any history of previous failed marriage or divorce should also be noted. History of domestic violence, sexual violence, stress, sleep pattern, medicine or substance abuse, exercise pattern, muscular orthopedic pain or arthralgias should also be elicited. Now, sexual history is very key in determining the vaginismus. Here, we have to start asking questions regarding a bonding with the partner. Questions like, are there any aversions or any offending factor? How is the sex life, sex behavior or sexual problems? Are there any sexual problems with the partner? Are there any interpersonal relationship problems? Was the marriage against her wish? Is there any fear of rejection or humiliation? Is there a lack of affection? Are there any communication problems among the couple? You have to ask questions regarding the consummation of the marriage. Is there any need of lubrication at sex should be found out? Then what is the sex frequency? Are there any desire? Are there any initiation problems, erotic thoughts? Is there any performance pressure should be elicited? Questionnaires like Female Sexual Function Index, FSFI, and CRIS gives an objective assessment. It's also very important for evaluation of medical disorders, endocrine disorders, psychological and psychiatric conditions. The main important part, the gynecological examination. It's very important. Now, examination of the external genitalia. First, we have to look out for any pain triggering spots. Look out for any post-surgical or post-infective scars. This can be an episiotomy or a bathroom cystectomy or any other surgery on the perineum. Look out for any signs of infection, dryness, atrophy, lichen sclerosis, thrush, warts, allergy. A muscle tone assessment can be done. A small speculum or a digital examination is possible after comforting and assuring the patient in case of secondary vaginismus. However, a pelvic examination requires IV sedation in primary vaginismus. Deep dyspareunia secondary to organic causes like endometriosis, PID, they should be evaluated with appropriate laboratory tests and imaging. Now, various treatment options are available. I'll be discussing a few of them in detail. Systemic vaginal desensitization. Desensitization using dilators, that is vaginal trainers, of gradually increasing sizes is the most commonly recommended treatment for vaginismus. And this is suitable for patients with less severe grades of vaginismus. Vaginal dilators overcome the physical aspects of vaginismus as well as the fear of penetration. Cochrane uncontrolled trial concluded that systemic desensitization with insertion training is effective for vaginismus if the outcome is measured by the ability to have an intercourse. Psychological, sexual, and behavioral therapy in conjunction with vaginal dilators leads to the best outcome. Dilators come in various sizes and materials. It's very important to instruct the lady on how to use the dilators, how to overcome the anxiety associated with the use of the dilators, important of progression to the larger sizes, and then transition to intercourse. It's also important to educate the lady on the sexual positions that allow relaxation of the pelvic floor muscles. Now, the dilator therapy consisting of the vaginal penetration exercise by the patient done in the presence of therapist or patient's partner have shown improvement of sexual distress, coital fear, and pain, and hence improved the ability to have intercourse. The patients are asked to dilate for 1 hour in the morning and 1 hour in the evening for the first month, then reducing this schedule as larger dilators become more comfortable for a longer period of time. With adequate use, patients are potentially able to sleep with dilator at night and progress with morning dilatation to the next size up. Pharmacotherapy with anxiolytics and antidepressants are used for patients with high levels of anxiety. Sensate focused therapy is about touching and being touched. The importance of touching is to be relearned. It consists of non-penetrative touching exercises that aim to increase the participants' awareness of their senses. It helps to overcome conscious mind and creates bond with self and with the partner. This can be either a self-sensate focus or partnered sensate focus therapy. Treatment of the couple and not just the affected women is recommended. 5 to 45% of the partners experience sexual dysfunction in the form of either erection disorders or premature ejaculation. Treatment involves vaginal dilators, tampons, or finger insertion, followed by sensate focus exercises with the partner or the surrogate. Studies have shown that the success rate of intercourse was 100% with surrogates versus 69% in established couples. This study highlights the importance of a cooperative, non-judgmental partner in the process of treating vaginismus. Sex counseling helps the couple improve their communication skills, dominate a compromised libido. It could also reduce anxiety and depression and is useful for less severe cases of vaginismus. Sex counseling is very important post-procedure, that is post-desensitization and post-Botox. Psychotherapy and hypnotherapy. Psychotherapy is aimed at reducing the anxiety associated with vaginismus and again helpful with less severe rates of vaginismus and also for women who underwent sexual abuse. Psychological interventions like cognitive behavioral therapy helps patients understand thoughts and feelings strategies and helps to reduce the pelvic muscle contractions. Gradual exposure to intercourse using cognitive behavioral therapy can decrease fear of penetration and decreases the avoidance behavior. Better results are obtained when they're used in conjunction with vaginal dilators and sensate-focused therapy. Hypnotherapy is a therapeutic intervention.
Just finish in 5 minutes, please.
Yes, sir. Yes, sir. Hypnotherapy is a therapeutic intervention leads the patient to persuade thoughts of more favorable outcome and experiences during intercourse. Identifying the organic causes and treating appropriately is very important. Use of Botox. Botox injections have promising treatment in mild, severe, and refractory cases. Now, botulinum is a heat labile neurotoxin derived from Clostridium botulinum. It's one of the most lethal substances which causes flaccid muscle paralysis. However, this is used in a highly diluted and purified protein form and works as a neuromodulator. Type A is the most potent and is used widely in aesthetic medicine. Now, botulinum is a neurotoxin protein which binds the presynaptic motor neuron terminal at the neuromuscular junction and hence inhibits the acetylcholine release. It binds to the SNAP25 or the synaptosomal associated protein and hence prevents the release of acetylcholine at the neuromuscular junction. Now, Dysport and Botox are the commercially available vials. Coming to the Botox injections. Now, each vial has around 100 units of Botox, which is diluted with 2 ml of saline. And this is injected in multiple areas along the lateral side of the vagina, that is into the bulbospongiosus and the pubococcygeus and the puborectalis part of the levator ani. The procedure is performed under sedation. Now, 15 to 20 ml of 0.25% with 1:2 lakh to 1:4 lakh epinephrine is also injected into the spastic muscles. Progressive dilatation is done, followed by an indwelling dilatation for the first time. This is the PASIC multimodal program. This speeds up the time of treatment intercourse to as early as 2 weeks, and patients are advised to use a series of graduated dilators for approximately 2 weeks before attempting intercourse. Women find it helpful to use a dilator for approximately 30 minutes before attempting intercourse, and lubrication is essential. Now, the average therapeutic dose is 20 to 200 units, but the toxic dose is 40 units per kg body weight. So there's a large safety margin in therapeutic and toxic dose. The effect of this is also temporary as the toxin is degraded gradually. Effect is seen as early as 1 week and lasts for 3 to 9 months. The most common side effects being pain, swelling, or bruising at the injection site. Vaginal dryness can be seen because of the parasympathetic blockade. Contraindications include muscular disorders, allergy to albumin, and in pregnancy and lactation. Summarizing the vaginismus is a common sexual problem noticed that causes distress and frustration for both the partners. Actual prevalence may be larger than apparent picture as most patients don't seek medical help at all. Proper evaluation, diagnosing underlying cause, ruling out differential diagnosis, determining the severity of vaginismus will help in formulation of best possible treatment regimen for the specific patient. In addition to conventional therapies, the recent use of botulinum toxin has demonstrated promising treatment option for mild to severe and even refractory cases of vaginismus. Multimodal approach of combining different therapies can have a better and early outcome than single treatment option. Thank you.
That was a very nice and exhaustive talk, Dr. Sindhu Lakshmi.
Thank you, ma'am.
Please stop sharing your screen.
I just want to say that since this is such a distressing thing for the patient, and when the patient comes to the doctor also the first time, the attitude of the doctor again becomes very important. And like you said, patients give time, nothing can be done in a hurry. And even at the first visit, gently introducing the patient to her own anatomy, reassuring her, encouraging her to touch herself, that goes a very long way in building confidence and making her feel that she has control of the situation from day one. Thank you very much, ma'am, for that excellent talk.
Thank you. Thank you, Neela, madam, for your kind inputs. And thank you all the chairpersons for chairing this session. I would like to hand over for the next session to my co-moderator, Dr. Apurva. Over to you, Dr. Apurva.
Unmute yourself, Apurva.
Thank you. Yeah. Thank you so much to the chairperson and to ma'am for the wonderful deliberation. Actually, before that, I would like to invite Dr. Gitanjali ma'am. Actually, yeah, Gitanjali ma'am, please unmute yourself.
Yeah, good evening.
Yeah,
good evening.
ma'am. Yeah, actually what happened, due to some reason of the speaker, we shifted the third talk to the first. I think that's why you, joined some late. But thank you so much, ma'am, for joining. Yeah, and I think you listened to this speaker. So, ma'am, your comments and about all the program. Gitanjali,
yeah, yeah. Thanks for the opportunity, and I'm happy we are having this in Punjab. This is because this is something which is not discussed. But I feel with coming times, females need to be equal on a same front as male needs. And so this is so very important to discuss about all this. And especially about all of these things, vaginismus, we get well-educated females with this kind of a problem. Marriages continue for 2, 3, 4 years, and the vaginismus being there and marriages not being consummated. So giving we also knowing all the procedures, like what she talked about, it was very good to know what all can be done, how the toxin can be given, how dilators can be used, and how they can be educated. So yes, these webinars are very important in present times.
Thank you, Gitanjali.
Thank you so much, ma'am, for being part and for giving us the time and joining this webinar in your busy schedule. Thank you so much. So moving to our last talk for today, I would like to invite two very senior gynecologists, Dr. Kulvinder Kaur ma'am. Ma'am is the professor of Government Medical College, Amritsar. Thank you so much, ma'am, for joining us. And our next Dr. Shweta Agarwal ma'am. Ma'am is the very senior consultant at the Akash Hospital, Firozpur. So thank you so much, ma'am, for coming. I would like to invite Dr. Shweta Agarwal ma'am to introduce a very dear senior and friend of my, I can say, Dr. Brajwala Tiwari ma'am. Over to you, Shweta.
Hello, everyone. Good evening, everyone.
Good evening.
And it was a very nice lecture involving all the problems which the patient come to us and we don't care about them most of the times. Most of the times it is ignored both at the patient as well as the doctor level. So it was very nice listening to all the senior gynecologists and friends. Now I would like to introduce Dr. Brijbala Tiwari. Ma'am is President Indore Obgyn Gynae Society and she is Director, Life Care Hospital and Santati Infertility Center, Indore. Over to you, ma'am.
Can I get the share screen option?
1 meter.
Yes, ma'am, you can.
I'm not seeing share screen option.
You are co-host. Already you are co-host.
Yeah, you are co-host, ma'am.
I was able to see previously. Now I don't know.
In the bottom, ma'am, in a green.
Yes, now. Is it visible?
No, not yet.
Yes, sir.
Is it visible?
No.
Now?
No.
I will
Ma'am,
share
are
it.
you login with
Who did?
iPad or?
I shared it. Is it?
No.
Just a moment.
Yeah, now it's
Yeah,
okay.
now. Okay, that's the reason. Yeah.
So good evening, everyone. And first
Yes,
of all, thanks to SMC committee, Dr. Neeraj and Dr. Apurva for making me part of this webinar. And all the topics were regarding the sexual disorders. So my topic is really altogether different, and the topic given to me is sex and sexuality in pregnancy. And it is a very beautiful part of women's life or other couples' life. And it is very unspoken subject. Pregnancy is the most significant period in life of women. Sexuality is an individual as well as a social construct that experienced and defined by individuals. Sexual feeling fluctuate throughout life. From the time of conception to the postpartum period, physical, physiological, hormonal, and psychological transformations place pressure on the women, and these can lead to secondary effect on partner. So this is very unspoken subject. The sexuality of expecting a new parents plays an important medical and psychological role. During antenatal and postpartum visits, physicians and patients have a tendency to avoid discussion of sexual issues. This is really very important issue, and we don't initiate regarding this. Impaired sexual function during pregnancy and in the postpartum period is not uncommon. So there are certain physiological inhibitory factors for sexual activity. The nausea and vomiting in early pregnancy due to increased estrogen progesterone. The breasts are tender in pregnancy due to increased prolactin. Sexual desire and performance are also hindered by during pregnancy. Heartburn associated with reflux esophagitis. Urinary frequency and urgency makes sex difficult. Constipation, fetal movements, all are contributing factors. Increase in amount of vaginal secretions. In third trimester, there is decreased desire, arousal, lubrication, orgasm. Satisfactions are reduced and pain is increased. There is increased vascularity in cervix, is more likely to bleed during pregnancy due to indirect trauma from penile thrusting. There is increased engorgement of genitalia and orgasm accompanied by cramping or muscle spasms. So these are the inhibitory factors. There are very late studies available. This was one of the study on Nigerian women regarding the frequency, perception, and complications of sexual activity during pregnancy, and they came out that this is really decreased as compared to pre-pregnancy. There are certain cultural factors. A taboo forbidding sexual intercourse for a period of time. Several religions, including Hinduism, Islam, and Judaism, restrict sexual intercourse. It's not a prescription that not to have sex during pregnancy, but women have in their mind. Cultural aspects have an impact on sexual function. The seizable reduction in sexual function is due to conservative behavior. In some culture, it is believed that the body of women is said to be wet and need to dry up, and male seminal fluid can harm the infant. So there are certain myths and fears. The danger of abortion, which is caused by the impact of penis against the cervix. Although it's not the fact, The number shock, animals do not copulate when the female is pregnant, the danger of infection, fear of injury to fetus. These are the certain potential complications of intercourse during pregnancy. And what the evidence are there regarding the preterm labor, no clear increased risk in patient with low risk pregnancy. There may be risk with genital tract infection and bacterial colonization in women with low risk pregnancy or with a history of preterm delivery. PID, one review with 57 cases in pregnant adolescent. There was only one case of tubo-ovarian abscess. APH not published, but there may be theoretical risk with placenta previa, venous air embolism. One review with 19 cases in pregnancy or puerperium. One review with 18 deaths from venous air embolism in pregnancy. This was really very new for me when I was making this presentation. And this is from the journal 2011. So what are the concerns regarding sex during pregnancy? Number one is infection. The vaginal infection in prematurity study group found that women who had frequent intercourse and were colonized with Trichomonas vaginalis, mycoplasma, bacterial vaginosis were at increased risk of preterm delivery. Frequent intercourse in women without such colonization were not associated with preterm delivery. Vaginal bleeding. Many women experience some vaginal bleeding or spotting, especially during the first trimester of pregnancy. Prematurity. This was the collaborative perinatal project, a large study conducted in the reported an association between high rates of premature labor and preterm rupture of membrane in intercourse during the third trimester. But all other studies have failed to confirm a relationship between coital activity and prematurity from a premature labor or LBW. There may be fetal distress. Larger and more representative investigations have observed no overall risk between sexual activity and either fetal distress or perinatal mortality. Proposed mechanism for prematurity or fetal distress include uterine contractions through female orgasm or through male orgasm, prostaglandins in sperm, transmitted infection, and mechanical stress through intercourse. This is from the American Journal, 1993. Venous air embolism following oral sex during pregnancy. Venous air embolism is an infrequent complication of pregnancy. Occur if air is blown into the vagina during orogenital sex and air traps beneath the fetal membrane and into the circulation of the subplacental sinuses, invariably causing death to both mother and fetus. And this was reported is the case of non-fatal air embolism following this insufflation in the 30th week of pregnancy. And there was hypotension, metabolic acidosis, acute neurological shock, and emergency cesarean section with eventual fetal demise. So with this syndrome is essential if prompt and appropriate intervention is needed. So we need to know about the knowledge of this venous air embolism following orogenital sex during pregnancy. So this was only one case I could get. Now, sexual intercourse during pregnancy and preterm delivery. So effects of vaginal microorganisms, the vaginal infection and preterm delivery study group. As part of multi-center prospective study, interviews and physical examination were conducted within genital cultures were obtained. Women seeking prenatal care from 23 to 26 weeks and 38 weeks interviews were conducted with a randomly selected samples, and they concluded that frequent sexual intercourse by itself is not associated with increased risk of preterm birth. However, women who are colonized with specific microorganisms and who engage in frequent intercourse have increased risk of preterm delivery. So it is not every woman is supposed getting infection in preterm labor, but there are certain indications to avoid sex during pregnancy. That is vaginal bleeding, placenta previa, cervical incompetence, premature dilatation of cervix, rupture of membranes, history of preterm delivery, and multiple pregnancy. So these are of course indications to avoid sexual intercourse. Now, proposed mechanisms of induction of labor by sexual activity. We know whenever nipple and genitalia stimulation happens, there is oxytocin release, and this causing uterine contractions. Although they are not strong contractions, prostaglandins released from mechanical stimulation of the causes cervical ripening. Prostaglandins in semen may cause cervical ripening. So these are the proposed mechanisms. This is one of very funny study, but I thought to speak about this from one of the journal. It is very old study, 1978. The sexuality of women in pregnancy and postpartum. A long period of sexual abstinence may also result in the seeking of extramarital affair by the husband for the that particular time. A study on 79 men, it was found that 12 sought sexual release outside the marriage during the pre-delivery abstinence period and 6 during the post-delivery period. So thus 25% of the men interviewed were unwilling to endure abstinence and sought extramarital affair during the pre and post-delivery period. So we don't have any recent studies on this aspect. Now coming to benefits of sex during pregnancy, sex during pregnancy gives some benefits to women and couple. These may be strengthen pelvic muscles preparing for labor. Better orgasm increases blood flow to genitalia. Keeping women fit and 6 burns calories and can help to keep both partners fit. Bonding between partners. Some couple find that sexual activity during pregnancy brings them together. Sorry. A boost to the immune system. A 2004 study found that sex increases happiness and antibody IgA that keeps colds and other infections at bay. And there is increased happiness. Orgasm releases endorphin, and that can help to feel happy and relaxed. And better sleep is associated with sex during pregnancy. There are many women complaining about the sleep problem during pregnancy, and particularly their husband says that she is not able to sleep during night, and husbands are working, they keep working in office, and the women sleeps during daytime and they are not able to sleep during night. So this was the benefit, and I found it to be very important to share. So basically it is the physicians who need to explain about the benefits and harms to the pregnant women and to the couple. Now, certain physical aspects of sexual activity postpartum. We know there is high levels of prolactin in lactating women that suppresses ovarian estrogen production with consequent changes in vaginal lubrication and atrophy of the vaginal epithelium, causing the sex to make difficult for women, and so the partner cannot enjoy sex during postpartum period, and they can be advised with proper contraception, some lubrication. So to conclude, the healthcare provider should discuss about sex during pregnancy. Gentle sexual practice can be opted by couple. Sex during pregnancy is a low-risk behavior except for some medical reasons. So for a healthy pregnant woman, there is a variety of sexual practice, and they can have sex during pregnancy. So this is all about sex and sexuality during pregnancy. So I must say that we actually physician, we obstetrician need to speak about this unspoken subject, because many times couple are hesitant to ask about whether they can have sex or not. And many times it is the husband whisper in the ear of wife to ask about this. And so it is we should come up with this. And thank you, Dr. Neeraj and Dr. Apur, for making this topic to speak. And really, I enjoyed to making this slides. Thank you so much.
Thank you so much, Brijwala ma'am, for the wonderful deliberation. So I would like to invite Kulvinder ma'am to please share your views or any comment or any questions.
Good evening, everyone. I think it is very well said and well covered by Dr. Brijwala. I think she covered all the points that it is not discussed prenatally also should be discussed with the couple. I think we discussed the various pros and cons of the sexual activity during pregnancy. So this is the most, I think, untouched topic, most important topic for the couples, for their relationship, and for preventing the conflicts between them and the various problems which they can face because of this sexuality during pregnancy, like already said by ma'am, that is the vaginal bleeding, preterm labor, PROM. She is prone for so many infections like trichomonal infection and the what you can say bacterial vaginosis. So ma'am, thank you ma'am, you have covered in a very elaborative way. So these topics should be discussed, I think, in the webinars frequently. So because in the future we want to make our patient as a couple comfortable for this. So thank you so much for making me a part of this as a chairperson. Thank you, Dr. Neeraj and Dr. Apurva and Dr. Brajwala and all the team of this webinar. Thank you so much.
Thank you, madam.
Thank you so much, ma'am. Shweta ma'am, Shweta Agarwal ma'am, your comments, please.
I was really astonished listening to that venous hair embolism as the cause of death in a pregnant woman. That was something very new for me, and all the points were covered very well. And personally, I am greatly benefited with this webinar. I was really astonished to learn that venous hair embolism is a cause of death during orogenital sex in pregnancy, in pregnant women. Very nicely covered all the topics, all the speakers. Thank you, sir. Thank you, Dr. Neeraj, for making me chairperson in this webinar.
Thank you, madam.
Thank you so much, ma'am. Thank you so much, ma'am.
Once again, thanks Dr. Neeraj and Apurva for keeping this type of webinars, really making aware among gynecologists and obstetricians. That is needed a lot.
We have at least covered 70% of the societies of Foxy till now. So since last 3 years we are doing this.
Yeah.
It's our mission. We reach almost all gynecologists of our Foxy members. So hopefully we can change the scenario.
I think that's a good effort by Dr. Neeraj.
Thank you, madam.
Thank you.
Thank
So,
you.
I think, sir, should we come for the vote of thanks? Yeah.
Yes.
So, Madan sir.
Yes.
Over to you.
Anybody
for the
wants to
vote of
comment
thanks.
anything? You are most welcome. Before that, anyone wants to comment anything?
Yeah, any question or any discussion, any comments by any of the guests, any of the speakers? Yeah, Lakveer ma'am. Yeah.
While we were talking of vaginismus, what I have found in my experience, rather than buying and asking for dilators where they are available, making it very obvious, transvaginal sonography, we do very gently with good amount of lubrication on the condom. Tell the patient to put the probe herself, give it in her hand, and making her very comfortable. Nobody else is there in the ultrasound room. Do it gently. Transvaginal probe, actually very nicely it can be inserted, rather than even trying your 1 finger or 2 finger examinations. And then next, if she is able to put it, and then you put it, you are able to put it, then call the husband also. By doing TVS, it will be very nice to show her, see, everything is normal. Your vagina is normal, uterus, cervix, you can see everything on the screen. All is normal. So I have found this a very good mode of therapy for these patients. So then make the husband put it, and in just 2 or 3 sessions, the problem is sorted out. This in among the residents who had these problems of different specialties, I tried. So when I gained myself confidence that yes, it is very good, so then even on all other patients called the husband and made them do. This is my experience on this topic.
Yes, madam. In some cases it can be done, but not all cases, because in some patient you touch the genital part and they will retract. So it's difficult.
Those are very few, actually, very few. You have to make them comfortable.
Yes.
Just make them comfortable, talk about everything. You just talk something different, their profession, education and all that. And very nicely you can do it also. and then show her on the screen, everything is normal. So why you are so hesitant? So in most of the cases, I found this as a very helpful tool. Okay, thank you.
Yes, please.
Thank you, Dr. Neeraj.
Neelam, sorry, madam, want to say something? You raised hand. Yes, yes.
Yes, I did, Dr. Neeraj, and hats off to you and the whole team's commitment. I know I'm a part of the sexual medicine committee and not having done any work at all, but at least I know what's going on. So you have reached out to a lot of people. What I would say that it is our mistake that we do not join in big numbers to attend the sessions.
Yes.
So, but you have the recordings available on Facebook. So anybody who's driven and motivated to learn more, and there are many practical sessions, and in fact, so much of nice repetition also, that we can get an answer to most of our questions. So that is something I would like to just say on this forum. There's a very nice Facebook page, Apurva. If it is possible to share the link in chat, maybe you could even do that, so that people, it reaches out. And the last talk on sex and pregnancy was perhaps the most, I think, entertaining of all also. I'm sorry to use the word. I mean, it's nice. We really had, there were so many interesting things which came up and so many new things which came up. So it was a very interesting talk. And I think each one of us needs to break our own barrier in asking patient questions on sexual related issues. Sometimes they're very simply dealt with, and the more we talk to each other, because we don't know. I think Neeraj Yadav sir's number can be shared and Apurva's number can be shared. So if in the OPD anyone has any problem, give a call to Neeraj Yadav sir and say, sir, I'm stuck here, you guide, and gradually we are all going to learn from there. So thank you very much.
Yes, we along with the certificate, we will send all the details, our Facebook page detail. Then we have video recording of our 2 masterclass series we have completed. So we will send that also.
Fine.
So please.
That'll be nice. Thank you. Okay.
Any other one want to say anything?
Thank you,
Iqbal,
Dr.
sir.
Neeraj.
Yes, yes,
Yeah.
Iqbal.
Thank you. It is a very nice webinar. Sexology is not a chapter. It's a big granth, you know. And once you start reading, I think you think this is more difficult than your obstetrics and gynae also. But chapter Dr. Bijbala covered very nicely. This is very simple question and often asked, and but no answer from many of the gynecologists. The third thing which I am observing is that most of patients are now refusing pelvic examination, the young girls. Previously, we just used to say this and they will have pelvic examination. Now, most of the girls avoid pelvic examination. So once they avoid pelvic examination, I think once they go for normal delivery or something, that also becomes difficult. But overall, this webinar is very nice. I'm very happy to be a part of it. Thank you very much.
Thank you, sir. So yes, Madan, just finish with the vote of thanks.
Yes, sir. On behalf of Sexual Medicine Committee of FOXI, I would like to, it's my pleasure to mention the thanks to all the FOXI office bearers, President, Secretary General, Vice Presidents, and especially the Chairperson of SMC, respected Dr. Neeraj sir, for this good opportunity and wonderful event we had today. I thank all the societies of today's webinar, Amritsar, Ludhiana, Firozpur, Jalandhar, and Chandigarh, all the office bearers and the delegates which were joined today. I would like to thank all the chief guests, Dr. Asha Bakshi ma'am, Suvarna ma'am, guest of honors, and all the esteemed speakers and all the esteemed chairpersons who participated on our request for today's event. And it was really a wonderful event. And thank you once again, all for joining today and making this event a grand.
Very well moderated meeting, very well moderated, time management, good, very good.
Thank you to Madan and Dr. Apurva for moderating all the webinar very efficiently.
Very good.
We had great